In this section, now we will talk about the clinical features and diagnosis of head and neck cancer. In this, mainly we will talk about the clinical presentation, how the head and neck cancer present, if they affect the patient, or what's the differential diagnosis. What are the different conditions we should differentiate from the head and neck cancer, and also what the approach to the patient who present with the head and neck cancer. So the clinical presentations of the head and neck cancer, if they occur in the young patient, they are usually HPV related malignancies. So human papilloma virus is the causative agent if it affects the young individual, and human papilloma virus is also associated with the cervical cancers, and people who are young and they begin with the early onset or early age at the onset of the sexual life or sexual intercourse. Those HPV has the cause cervical cancer also. So mainly HPV affect the individuals who are young and not old. So it's HPV related malignancy in the young. EBV, Epstein-Barr virus related nasopharyngeal cancer, as compared to HPV, it affects the all ages. So young people, middle age or old age, all ages are affected by the nasopharyngeal cancer caused by Epstein-Barr virus. Then we have otolaryngologic examination should be performed to find out the growth or the tumor. Nasopharynx cancer, usually with the nasopharyngeal cancer, there is no early symptom. So patients do not have any early symptoms if there is nasopharyngeal cancer. Unilateral serous otitis media, unilateral or bilateral nasal obstruction also present. So nasopharyngeal cancer, no early symptoms. Unilateral otitis media or flow discharge from the ear is present, and also there is unilateral or bilateral nasal obstruction. Epistaxis is also present in the nasopharyngeal cancer because now the tumor spread to the nasal side and it can cause epistaxis or bleeding. Advancements, usually we have neuropathies of cranial nerves occur with the spread of the cancer from the nasopharyngeal region. So HPV related malignancies occur in young individual. Epstein-Barr virus related malignancies affect all age groups. Early in the period of development, usually nasopharyngeal cancers are asymptomatic. They do not have any symptoms, but later on, as the cancer spread to the different sites, there is epistaxis, nasal obstruction, and then there is cranial nerve neuropathies occur. There are 4 cranial nerves, and when the tumor spread to those sites like facial nerve, and then we have olfactory nerve, optic nerve, all these cranial nerves, when they are affected by the tumor, then they present as different neuropathies. So these are the clinical presentations. The manifestations vary according to stage and primary site of tumor. So as we went over the staging is very important depending on the presentation. If the early stage, usually early stage is asymptomatic, so that's why it's hard to diagnose the cancer in the early stage because of the no symptoms present. So as the cancer spread and cause invasion of the different structures or different parts, it can have different clinical presentations. So manifestations and prognosis mainly depend on the stage of the tumor at which it is present. This is the nasopharyngeal tumor that is present or involved, affects the nasopharyngeal area. Males frequently affected by this cancer or malignancy. Next, how the carcinoma of oral cavity present as non-healing ulcers. This is the cancer of the or carcinoma of the oral cavity. If it's present in the mouth, usually it present as non-healing ulcer. Ulcers are produced which are not getting better with different treatments, raise the suspicion of malignancy or cancer. So biopsy should be done from the non-healing ulcer to rule out any malignancy. Changes in fit of dentures, that's another clinical presentation of the oral cancer. If patient wear dentures, those dentures, they become loose fitted and they are not fitted well. Painful lesions are also present. Tumors of tongue, usually decreased tongue mobility is present. If the tumors are present on the tongue, you can see this picture of the tongue tumor. If they are present on the tongue, the mobility of the tongue or movement of the tongue is decreased. Alterations in speech. Speech is also affected with the tumor of the tongue. Cancer of oropharynx or hypopharynx rarely cause early symptoms, sore throat or otalgia. So that's how the staging is missed because no symptoms are present in the early stage of the cancer of the oropharynx and hyperpharynx, and the symptoms which are present are like sore throat or pain in the ear, and these symptoms are very common with the conditions like common cold, sinusitis, strep throat and tonsillitis. So that's why the diagnosis at the early stage is missed. Laryngeal cancers, usually they have larynx is the voice box. Sound is produced by the larynx. So if larynx is affected, it causes the hoarseness of the voice. Indirect laryngoscopy or radiographic studies are performed to diagnose the laryngeal cancer. So all these are the clinical presentations of the carcinomas present in the oral cavity. So there is decreased mobility of the tongue, there is pain in the ear, there is sore throat, hoarseness of the voice, depending on the site of the development of the cancer. HPV related tumors present with neck lymphadenopathy as first sign. So if the tumors are developed by human papilloma virus, they involve the lymph nodes in the neck, and that's the first presentation of the HPV related cancers. The clinical presentation: severe pain, otalgia, airway obstruction because it is in the pharynx, oropharynx, hypopharynx. The airway is obstructed, and there are also cranial neuropathies. Trismus and adenophagia, pain on swallowing. Trismus is the mandible is locked, there is lockjaw. So lockjaw is trismus that's present, and there is pain on the swallowing. dysphagia, decreased tongue mobility, fistulas, and there is skin involvement, cervical lymph adenopathy, and enlarged lymph nodes. So all these are common clinical presentations of the oral cavity, nasopharyngeal cancers, oropharyngeal cancers. There is dysphagia, difficulty in swallowing, there is trismus, there is pain in the ear, also there is airway obstruction. All these conditions, there is cervical lymph adenopathy, enlargement of the lymph nodes in the neck, and fistulas formation. As the tumor spread and it involves the different structures, there is joining between the different structures or the organs, leading to the formation of the fistula. So these are some clinical presentations of the cancer. Now, the differential diagnosis, what are the conditions from which these tumors should be differentiated? By the inspection of mucosal surfaces, observe for leukoplakia or erythroplakia, biopsy and CT scan, and then staging procedures. PET or positron emission tomography, endoscopic examination under anesthesia, laryngoscopy, esophagoscopy, bronchoscopy, microscopy of lungs, bones, liver, lymph node excision, and pan endoscopy. So these are some basically the tests which help us to differentiate between the head and neck cancers from all the other conditions that can occur and that can sometimes produce the symptoms like the tumors. So they should be differentiated from the head and neck cancers, and all these tests help us to differentiate. This is the laryngoscope going in the larynx to find out if there are any growths or the tumors or neoplasm present. So we should observe for leukoplakia and erythroplakia also, because these are the features of the development of the cancer. And then by PET, endoscopy, laryngoscopy, these are all the different tests that help us to get the biopsy, look for the site, look for the area, look for the extension and invasion of the tumor, and how badly is the spread or involvement. And it is classified according to tumor node metastasis. We already defined what it is and how the involvement of different lymph nodes, staging of the tumor, and how far is the metastasis. TNM is used, T1 to T4. All these are the stages of the tumor. Approach to the patient with cervical adenopathy. There is physical examination in the office can help us to look for the lymph node involvement or the swelling of the lymph node. A fine needle aspiration or excision of the lymph node is also done. Then if lymphoma, sarcoma, or salivary gland tumor, then we should go for the specific workup for the treatment of the cancer. If squamous cell carcinoma, then we should do pan endoscopy and directed biopsies. Search for occult primary with biopsies of tonsils, nasopharynx, base of the tongue and piriform sinus. So approach to the patient is, if the first we said is the spread of the tumor to the lymph nodes in the neck. So look for the lymph nodes in the physical examination in the office. Then go for the fine needle aspiration or excision of the lymph nodes. Send them for the biopsy. If there is lymphoma, sarcoma, or salivary gland tumor, go for the specific workup. If it's diagnosed as squamous cell carcinoma, then we should do different biopsies, specific directed biopsies, with the aim to look for the primary site. And then we have to do biopsies of the different sites, including tonsils, nasopharynx, base of the tongue, to look for the site of the primary lesion or from where the tumor started, if in case of the squamous cell carcinoma. Stage-specific multi-modality therapy is done, and then consider curative neck dissection. So in this case, once the biopsies are performed, then we should go, after the biopsy, we know what stage the cancer is at, and then we should do the stage-specific therapy and curative neck dissection, so to limit the spread of the cancer. Post-operative radiotherapy or chemotherapy, once the lymph nodes are dissected from the neck, then we should go for the chemo and radiotherapy. This was all about section 3. Thank you for watching sqadia.com.